good amount of people on. I'm going to start to kick us off. So welcome everyone. It's so great to see so many people. We hope people are doing well, keeping safe, keeping healthy. Your families and friends are well during these times, and it's great that we have been able to host these rounds like this with great attendance and participation. So thank you all for being here. I don't have any particular announcements, Stephen, or if anyone has something they'd just like to share or announce with this group in terms of an event or something of importance that can be done right now.
Nope, nothing offhand.
Okay. For everyone, just a reminder, I can see just about everyone is, to keep yourselves on mute during the presentation. And you can open up and unmute yourself when we get time for discussion. And you can also please use the chat box. And in the chat, you can ask a question, or you can just simply put in your name and say you'd like to ask a question. It's always good when people we hear their voices. So, but either way, and there will be time for discussion at the end of the presentation. And welcome to everyone. And thank you so much, Dr. Bowleg, for being here with us. I'm going to do a very brief, quick introduction. We want to get to her presentation. Lisa Bowleg is a professor of applied social psychology in the Department of Psychological and Brain Sciences at the George Washington University, and she's founding director of the Intersectionality Training Institute at George Washington. Her research focuses on the intersectional and social structural context of health for Black heterosexual men and Black LGBT communities. She's associate editor of the American Journal of Public Health and the section editor of AGPH's Perspectives from the Social Sciences. I'll just say personally, I've certainly known of Lisa and her work for many, many years, and she's definitely a sought after presenter, and I think that's one of the reasons we have so many people already in attendance. And she's talking on a topic that is absolutely at the heart of what is needed in our country as far as the HIV pandemic. We still have an HIV pandemic along with COVID. And so we need to keep this high priority at the top of the list, especially during these times. We're talking about vulnerable communities at the get-go. And so they're vulnerable for, the damages to communities of COVID, just like HIV. I think none of us here are surprised. I think it's been a bit of an eye-opener for the country. Some people unfortunately are surprised that we have the health equities and disparities that we do in this nation. So Lisa, thank you so much for being here and talking to us, particularly on this very important topic. I turn it over to you.
Thank you. Good morning, everybody. I want to thank the HIV Center for the invitation. Of course, when I received this invitation, I totally planned to be there in person. And thank you in particular to Dr. Sanford and to you, Dr. Remien, for this invitation. It's also nice to have the invitation to put on professional clothes. I've been in sportswear for the last, sort of 3 months or so. And so this is a treat as well. So, I'm talking about intersectional stigma today in the context of improving HIV prevention for Black, gay, bisexual, and other men who have sex with men. And a lot of my talk is going to be about sort of transcending how we talk about intersectional stigma. And you're going to hear some of my sort of struggles with this concept. So what I'm going to do is just give an overview, and it's going to be very quick because most of you already sort of know how dire and urgent the context of HIV prevention still is for Black GBMSM. I'm going to say that, I'm going to trip over that several times, but for brevity. And then I'm going to get into intersectional stigma and really give sort of a 101 so that we're all on the same page about what I mean when I'm talking about intersectionality, when I'm talking about when I say stigma, and also what I'm talking about when I say intersectional stigma. And then I'm going to talk about why it's so important to bring structure and social structural context. I use those terms interchangeably a lot into our work. And I'm going to talk a little bit about our Prism project, which is an HIV prevention study on intersectional stigma that we were just gearing up when COVID-19 hit. And so that study's on pause. And so this talk is going to be really sort of more sort of conceptual. I won't have any data to present from that study, but it's a study where we're trying to develop measures of multi-level intersectional stigma. So I'll talk a little bit about that. And then I'll close with some thoughts I have about things we need to do to improve HIV prevention for Black, gay, bisexual, and other men who have sex with men. Some of it related to intersectional stigma and some of it beyond that. All right. So we start here, and you likely saw this piece, which was in the New York Times Magazine by Linda Villarosa about 3 years ago. And the subtext of this is, you know, why do America's Black, gay, and bisexual men have a higher HIV rate than any country in the world? You know, why indeed, right? And this piece really sort of takes you into all of these sort of structural inequities, particularly for Black men in the South, and how for many of them it was sort of like 1981, the discovery of HIV in terms of lack of access to information, to testing, to PrEP, and so on. And so a lot of what I'm talking about really sort of fits in with this sort of larger theme that it is more of a structural issue than an individual level issue when we talk about HIV. And so most of you already know that Black men are Black, gay, and bisexual men and other men who have sex with men are disproportionately represented among those who have HIV. This sort of startling projection came out of the CDC a few years ago that if current trends continue, 1 in 2 Black, gay, and bisexual men could expect to test positive in his lifetime. And the thing that's always sort of brought home how sort of jarring this sort of disparate impact is we're talking about a really sort of tiny percentage of the Black population. And this is a report from AMFAR asking, do Black gay lives matter? And showing that Black gay men are about 1.4% of the Black population, but yet account for the vast majority of infections each year. And so our work on this particular study fits within this sort of HIV prevention continuum, not so much on treatment, but basically on the sort of green box here about these sort of, what are the different tools in the toolkit that might be sort of harnessed to prevent HIV in this group. And so they focus on, you know, things like sort of PrEP, pre-exposure prophylaxis, which has been shown when taken consistently and correctly to reduce incidence of 99%, condoms, of course, and HIV testing. And so where I want to talk about a bit is about the research evidence, because what we know, and several studies continue to tell us, is that when we look at Black, gay, bisexual, and other men who have sex with men compared with white men or Latino men, we find fewer risk behaviors. They report engaging fewer risk behaviors. They report less anal sex, more condoms. And again, sort of they're doing all of the things that HIV prevention specialists and public health professionals say they are to do, right? Fewer sex partners, less drug use. And Greg Millett has really been a sort of at the forefront of a lot of this work. And yet, still these really high rates of HIV and particularly use of PrEP. And so this, for example, is a 2019 study showing these sort of great inequities in PrEP use, comparing Black men who have sex with men, white, Latino, and Black and Latino and white men. And so the sort of lighter shade box here is Black men, and you'll see lower rates of PrEP awareness. And so for Black men, it's about 86% compared with white men. And I should say these are statistically significant differences. About 95% of white men have awareness of PrEP. And then you see things really drop off in terms of people who've discussed PrEP with a healthcare provider. And so 43% of Black men had done so compared with 58% of white men, and then actually lower rates of PrEP use. And so in the last year, 42% of men in the study reported using PrEP compared with 26% of Black men. And what's interesting about this study is that they also had similar rates of health insurance and also similar rates of access to care. And yet we still see this disparity. So this takes us into sort of this concept of intersectional stigma. And increasingly that this is being used as a concept to sort of try and explain why we keep seeing these inequities in this group. And so think of it as sort of an amalgam of intersectionality and stigma. And so I want to just give a sort of little, very quick introduction to intersectionality and how I see it. I always start here when I talk about intersectionality. Intersectionality is this sort of critical theoretical perspective. It's really sort of traveled and is sort of firmly entrenched in the academy. But I think that most intersectionality scholars agree that we rightfully need to begin with Sojourner Truth as sort of the original intersectionality theorist. And so Sojourner Truth, former enslaved person, and this is her famous Ain't I a Woman speech that she's given in 1851 to a women's conference in Akron, Ohio. And she gives this famous speech where she says, this is just an excerpt. That man over there says that women need to be helped into carriages, but nobody ever does that for me. Nobody ever gives me the best place, and ain't I a woman? And oh yeah, she's a woman. But the condition that she's describing is that she's a Black woman. And so that her race intersects with her gender in this way that they are so mutually interlocking that you can't understand one absent its connection with the other. And then I often see this as also an example of intersectionality. And in my work, I've been sort of using this theoretical framework and applying it to other sort of different groups, like marginalized groups, including Black men. And so this is the famous sanitation workers strike. This is where Dr. Martin Luther King Jr. was when he was assassinated, standing in solidarity with sanitation workers who are marching and protesting that they are men, because of course they're being denied all of the sort of benefits that their white counterparts are. And they're asserting that they're men, and clearly they're men, but their issue is that they're Black men. And so that sort of gender intersects with race. But intersectionality is not just about sort of the demographics. Intersectionality is sort of fundamentally about power and social inequality based on demographics. And so, we intersectionality scholars, we're often talking about what's happening with this sort of flattening of intersectionality, where increasingly we talk about it as, sort of multiple identities, but we really don't talk about it as power and inequality based on those identities. So lots of different definitions of what intersectionality is. Again, I wanted to start with Sojourner Truth because intersectionality does not necessarily sort of come out of the academy. It really comes out of sort of Black feminist activism and experiences, and it's sort of traveled into the academy. And so here's one of many definitions. It's one I offered in a piece that I did in the American Journal of Public Health in 2012. And one definition is it's a critical, theoretical, or analytical framework. I like thinking about intersectionality very much as a framework versus a theory, and that's primarily because I'm trained in applied social psychology, where theory has a very sort of different specific meaning, something that you test. Anyway, it posits that multiple social categories are interlocking at the individual level of experience. So if people tell you about their sort of lived everyday experiences, but this is the critical part. But what those experiences actually do is reflect multiple interlocking systems of privilege and oppression at the social structural level. So that's how we get into talking about intersecting racism and sexism and heterosexism, and you can keep going. So as for stigma, stigma comes out of the sort of sociological tradition, and one of the most famous proponents of this view is Irving Goffman, who was a Canadian sociologist, and this is his famous book in 1963, where he talks about stigma as an attribute, this sort of discrediting thing, and talks about stigma as the situation of the individual who is disqualified from full social acceptance, and the stigmatized individual is reduced in our minds from a whole and usual person to a tainted, discounted one. And so this concept of stigma has been really sort of influential, not only in sociology, but also in psychology. Now, of course, one of the problems when things get into psychology is that, in psychology, the individual is the primary unit of analysis. And so we typically just sort of view things through that lens, which I, as a critical psychologist, see as highly problematic. And so the work that's been, as I think about stigma, and particularly stigma in the context of intersectionality, I've been really most influenced by sociologists and sociologists coming out of Columbia, particularly Lincoln Phelan's work on conceptualizing stigma. And I have to confess that when I saw that intersectional stigma was really becoming popular, and that NIH was, in particular, was interested in this topic, I was a little concerned because I'm really not a fan of sort of traditional conceptualizations of stigma. And Lincoln Phelan in this article articulate some of my concerns so beautifully, and so I'll share them with you. So what they say about the problem with the term stigma, particularly how stigma has sort of traveled through the years, is that we don't think about discrimination so much when we think about stigma. The quote in their article is, "The term stigma directs our attention differently than a term like discrimination. In contrast to stigma, discrimination focuses the attention of research on the producers of rejection and exclusion." So in other words, on the people doing the discrimination, right? And for those of us interested in interventions, that's critically important, because what we want to do is we want to modify discrimination. We want to eradicate it. We want to stop it. Rather than on the people who are the recipients of these behaviors. Thus, the terms we use could lead to different understandings of where responsibility lies for the problem, and as a consequence to different prescriptions for action. So a lot of sort of implicit in a lot of the work on intersectional stigma is that the stigma lies within bodies and within individuals, in particular, people who are Black and gay, bisexual, and have men who have sex with men. And I see this as highly problematic, because there's absolutely nothing wrong with those positions, right? The problem is about the people who are doing the discriminating based on those positions. And so Lincoln Phelan sort of give a definition or lay out the conditions under when stigma happens. And why I really love their definition is because they put power at the center of it. So stigma exists, according to Lincoln Phelan, when people distinguish and label, right? And which is something we do all the time. We're very, cognitively, we're very efficient in that way. We label differences. Two, when dominant cultural beliefs link labeled people, the people that we've applied labels to negative stereotypes or undesirable characteristics. Three, there's a separation that happens, right? So they're the label people, and that's, that's the them, and they are very different from us. And usually it's devalued, these distinct categories. And that the labeled people experience status loss, and the discrimination leads, as we all know, to inequitable outcomes, whether we're talking about, well, anything, HIV prevention, interactions with police, anything. And it's entirely contingent on access to social, economic, and political power. And so this is a really sort of important sort of definition of stigma, and it's sort of where I stand when I think about stigma. So I want to talk a bit about sort of intersectional stigma and its application to HIV prevention research. Um, this is a study, a qualitative study by Dr. Catherine Quinn of the Medical College of Wisconsin that talks about the impact of intersectional stigma and PrEP use. And what I want to point out about this is why, just as an example of why it's very important for researchers to be real sort of crystal clear about how we're operationalizing our terms, because our research is often taken up and sort of disseminated in ways that we don't know. So this is a headline that describes this study in Pause, and it talks about intersectional stigma being tied to limited PrEP uptake. One issue here is that this was a qualitative study, and so it sort of can't establish any sort of links in this way. And the other thing that this headline does not address is that both men who used PrEP and those who didn't reported the same type of intersectional stigma. So just, always, we're not always sure of how our research sort of travels, but I wanted to just point that out. So Lincoln Phelan and also Parker and Eggleton in their work lay out these sort of critiques about stigma, which pretty much are the ones I have about intersectional stigma. I mean, they're virtually identical. One of the things they said is that, for example, stigma is often rarely defined in research. People just say it, but it's not operationalized. The individual is front and center, as I've already highlighted, that, and relatedly, that stigma is sort of put inside the person rather than on the people apply or systems applying the label, and that ignores the role of power and structural inequality, which pretty much are sort of my sort of reservations about intersectional stigma. Particularly in lots of the research and literature, there are no definitions of it. And one of the things that's always been interesting to me is that when I go to look for definitions, I often see my work cited. I'm like, oh no, I've never defined intersectional stigma. But this is an example of a really great paper highlighting some of the challenges and opportunities. And one definition they give is that intersectional is a concept that characterizes the convergence of multiple stigmatized identity within a person or group, and to address their effects. Again, sort of really sort of more in that sort of individual category that I talked about earlier. Another issue is, prioritizing the individual. Same thing as Lincoln Phelan noted. But my biggest reservation is, again, the lack of attention to power and structural inequality, and particularly focusing on talking about racism and white supremacy. There's a way that it's easier to talk about intersectionality and talking about intersectional stigma when lots of times we really should be also talking about racism as a system of oppression that affects Black, gay, bisexual, and MSM. They are not immune to this. And so I want to show you some examples, and this is sort of with apologies to to NIH, who sort of funds my intersectional research. But on the one hand, I was really thrilled to see that the National Institutes of Health is taking up the concept of intersectionality and intersectional stigma. But you'll notice that their definition of it is basically multiple stigmatized identities, which does not address this issue of power that is so salient to any work on intersectionality, and certainly to any in line with Lincoln Phelan's work and Parker and Appleton's work on stigma. And so I always like to show this. This is a fantastic article towards the field of intersectionality studies, in which Sumi Cho and Kimberly Crenshaw and Leslie McCall sort of talk about, you know, a lot of the different sort of debates and approaches to intersectionality. And one of the things they say, because I mean, you know, as you might imagine, there are lots of debates in the field about how do you define it, what methods should you use, who should you be citing, all of that type of stuff that we scholars, you know, spend a lot of time on. And they say, what makes an analysis intersectional, whatever terms it uses, doesn't matter, whatever discipline it comes from, it's its adoption of an intersectional way of thinking about the problem of sameness and difference and its relation to power. So to me, what this means is if you're not talking about power, you're not talking about intersectionality. And so they also have this notion of intersectionality as a sort of a disposition. It's sort of a lens that you use, a critical analytical lens that you bring to sort of just about anything. And then related, I wanted to show you this because related to this is work on stigma within HIV that really brings home this concept of why we need to bring power to our discussions of stigma. We need to reframe our understanding of stigmatization and discrimination to conceptualize them as social processes that the only way you can understand them is in relation to broader notions of power and domination. So this is something that I've sort of advocating for in intersectional stigma work, that we're always bringing in the point about power and inequality. And they have a longer quote that I wanted to share about defining stigma. Stigma causes some groups to be devalued and others to feel that they are superior in some way. Ultimately, therefore, stigma is linked to the workings of social inequality, and to properly understand stigmatization and discrimination, whether in relation to HIV/AIDS or any other issue, requires us to think more broadly about how it is that some groups come to be socially excluded, and about the forces that create and reinforce exclusion in different settings. So we apply this to intersectional stigma, right? And you see that this takes us in a totally different direction, because we're not talking then about people with multiple identities, because technically everybody has a multiple identity. But we're talking about power and the role of sort of power and exclusion. And we see this application of sort of power happening more and more. In our article, we define we talk about stigma happening at multiple levels: interpersonal, community, and structural, and really drove home this point that it's not the intersecting identities that's the issue, but it's the power, privilege, the oppression based on those intersectional positions. And I should say here that increasingly you're hearing me talking about intersectional positions rather than identities, because, well, one, identities shift. They're socially constructed. Often we label people without knowing how they identify at all. And a lot of it is sort of based on projection, the identities that we think people have. And so increasingly in my work, I've been talking more about intersectional positions rather than identities. So prioritizing power and structure in intersectional research. First, about structure, and I usually use structure and social structure sort of interchangeably, but a lot of my work on this comes from Kim Blankenship's work, and she talks about structural approaches as anything that locates public health problems and factors in the social, economic, and political environments, and that shape and constrain the ability of individuals or communities to to engage in protective behaviors. And why I think we need to bring more of a structural approach to our intersectional work is because we have mounds of evidence showing us that for Black, gay, bisexual, and other men who have sex with men, many of the barriers to HIV prevention are in fact structural. This is just a glimpse of lots of different work on this showing, for example, HIV, high HIV prevalence among Black men who have sex with men in the US in terms of incarceration. Jose Bauermeister's work on neighborhood context and where you live. And it's something that David Malebranche and I have written about before, that it's so much more beyond gay, bisexual, or, or down low. And so I want to just sort of highlight some findings from the Levy et al. Study, this one here, where they did a review of the literature to try and understand what were some of the structural barriers related to HIV testing and HIV prevention. And they found this across different articles. They found that lack of health insurance, that going to healthcare, the perception that it's just too costly to go and see a healthcare provider, lack of testing or low availability of testing in correctional facilities where Black men are disproportionately represented. And then we get into these sort of more informal social influences that are directly related to what we're talking about when we're talking about intersectional stigma. So racism and homophobia in interactions with healthcare providers, issues about disclosing sexual behaviors to healthcare providers, stigma and discrimination in general, stigma of what happens when you test voluntarily, the lack of cultural competency that many healthcare providers have in terms of discussing sexual risk or protective behaviors with Black, gay, and bisexual men, or just talking about issues of sexual identity. Again, a lot of this stuff is focusing on the system, experiences of stigma within social interactions with healthcare providers. And then, of course, other structural issues such as many Black, gay, bisexual, and men who have sex with men live in areas with low density of HIV prevention services. The other reason why we need to focus on, why we need to transcend the individual level is because doing so allows us to address things that are really sort of modifiable, things that we can actually do something about, right? Our intersectional positions of what they are. This also gives us the potential to have larger impact in terms of preventing HIV at the population level rather than at the individual level. And another issue is that intersectional stigma, when we talk about it in terms of stigmatized identities and multiple identities, really sort of sets up inequality as something we just can't do anything about. And my colleague, Greta Bauer, in writing about intersectionality and why we need to focus on social processes such as discrimination and not just identities, really sums it up so beautifully. She says that focusing primarily on social identities positions runs the risk of continuing to reinforce the intractability of inequity, albeit in a more detailed or nuanced way. So yeah, it's more nuanced to talk about interlocking identities and multiple positions and all of that, but it really does not move us beyond, okay, how do we modify the systems that create the oppression in the first place? And then there's this issue about if we focus on structure, we are shifting the balance away from just sort of blaming individuals and holding them responsible, holding them sort of solely responsible. And here I turn this over to the fabulous Dr. David Malebranche. And you may have seen this talk that he gave at IAS in the International AIDS Society Conference in 2018. He's talking about the HIV treatment cascade and how, it's how Black, gay, bisexual, and other men who have sex with men are pretty much just sort of left out, and are stigmatized and held and blamed and held responsible. And I couldn't give this justice. And so I wanted you to hear this sort of clip of David talking about and the analogy he uses.
This is Gordon Ramsay. Why am I putting Gordon Ramsay on a treatment cascade slide, you're wondering? I want you to imagine, I'm gonna create an image for you here. Imagine a restaurant opens up in your city where 100 people come once, eat a meal, but then 2 months later, only 40 of them return to eat another meal. Would the restaurant sit back and conduct a study to figure out what's wrong with the consumers that they won't continue to patronize their establishment? You all know the answer to that, they wouldn't. The leadership would take a look at themselves. They would ask questions. Does the food taste good? Does it need more seasoning? Did Karen put raisins in the potato salad? Are the ingredients fresh? Where is the location of the store? How are we advertising to the community? Is it convenient to our consumers? And how about customer service? Are our staff friendly and courteous enough? Are they treating the customers with dignity and respect? That's what a good company would do if they were truly trying to provide a service to the community. Unfortunately, most research on Black MSM and the treatment cascade ponders what's wrong with the vulnerable community first and looks at the medical community much later, if at all. Stigmatizing phrases such as "they are hard to reach," "don't trust doctors," or "uneducated" are far too common and absolve medical systems from holding themselves accountable for not just access, but the quality of health services we provide. Maybe we should be asking questions like, what are the community's priorities? Are we actually the right ones to provide clinical services? Is the paperwork for funding too much for staff to stay on top of? Is the certification process to engage in the clinic so cumbersome that it deters patients from completing it? Is our location or clinic name stigmatizing so much that people don't want to come? Or have we trained our staff in cultural humility so they don't make patients feel more stigmatized than they already are? Simply blaming the victim never gets us far in public health, but that's exactly what we seem to be doing when it comes to vulnerable communities in the HIV treatment cascade. This is Gordon.
I just couldn't have said it better. So that when we're talking about HIV prevention, so much of the time the focus is on, what's wrong with them? Why won't they be tested? Why won't they use condoms, even though we know that they are? Why won't they disclose their status with their healthcare providers? And it's a way that we take the onus off of healthcare providers and systems. And so David just said so eloquently and so beautifully. And so I wanted to sort of share that. So really quickly, I'm going to go through sort of our study on intersectional stigma. And like I said, this is a study that's been paused by COVID-19. We received an R21 exploratory grant in response to this NIMH's promoting reductions in intersectional stigma to improve the HIV prevention continuum. And what we said we would do, we were not original with our name. We figured a 2-year study, we're just going to name it Prism after the mechanism. And what we want to do is we want to develop and validate measures of stigma, not just on the individual level, right? Asking people about their sort of individual experience, their internalized stigma or their enacted stigma, but we really want to understand about sort of stigma at the community level and at the structural level. And it's focused in Jackson, Mississippi, and DC, in sort of southern states, because as this slide shows, southern states are disproportionately represented in terms of people with new HIV diagnosis, that Black, gay, bisexual, and other men who have sex with men represent something like account for 6 in 10 of new diagnoses in the southern United States. And so this is why we put our study there. This is the study team, University of Mississippi, Jackson, Dr. Leandro Mena, Paul Burns is our co-investigator, and in DC we have Dr. Shanika Hall, who was the evaluator for the community, for the acceptance journeys social marketing campaign, Dr. Tamara Taggart, who is bringing to the team sort of this notion of spatial stigma, and we wanting to understand like where the neighborhoods or places that Black men go or don't want to go, and what might that teach us about the role of intersectional stigma and HIV prevention services, and Dr. Ana Maria Del Rio Gonzalez, who is doing a lot of our statistical work as a co-investigator on this study. And we also have Ron Simmons as a consultant to this study. And so we adapted, this is sort of our conceptual model, which we adapted from Carmen Logi's work on intersectional stigma. This is not, you know, my critique of this, of our diagram here is that it shows all these types of stigma as sort of Venn diagrams, which from an intersectionality perspective doesn't work, because intersectionality says all of these are interlocking, and so that you can't sort of separate the pieces. But nonetheless, this just shows how we're conceptualizing stigma, and we want to know about what happens and we're doing qualitative interviews to find out what happens in those interactions with healthcare providers. We want to know about stigma at the community level, you know, what's on social media, what's in the religious institutions. And we, of course, are comparing Jackson versus Washington, the context for men in Jackson, Mississippi versus Washington, D.C. And then we also want to know about this sort of structural stuff. We want to know how participants reported, but we also want to create indices of that. And I'll show you a little bit of what that looks like. So we have three aims for this study. We want to develop these quantitative measures based first on qualitative interviews that we're doing with men in DC as well as Jackson. And then we want to develop these sort of spatial visualizations. We're actually asking men to tell us where they go and, you know, where they don't go and why. And then we want to develop these quantitative measures, assess the psychometrics, and then we're going to combine all of them as you do in mixed methods work. It's an exploratory sequential design. And I'm not going to go through all of this because we got stuck right here with COVID, but this basically just sort of shows how we're going to do these. We're doing Rika Boone, my doctoral student has been and Mary and Baba, two doctoral students, have been really instrumental in doing a lot of the policy reviews. And then we're supposed to be doing interviews, and then we're going to do you know, cognitive interviews and lots more to go. But this has all been sort of halted for the time being. The eligibility criteria is that they're self-identified Black, gay, MSM in both cities. They have to be HIV negative and between the ages of 15 and 34. Before COVID, the plan was that we would test to verify HIV negative status. Now what we're doing is moving the study online so that we would do the interviews and that requesting referrals from providers of people they know have tested negative. Lots of limitations to that, but you know, we, like most researchers, have had to adapt. And what this shows is just these different measures that we want to create about structure and community. And I want to give you some examples of some of the things we're interested in terms of trying to understand, develop indices of structural stigma. One of them, for example, a big one, is Medicaid expansion. So if we look at PrEP use individually, we get into, you know, awareness of PrEP and what do they know, where they want to use it or not. But a big structural context is states that have expanded Medicaid versus those that have not. DC expanded Medicaid, and so DC is able to offer PrEP assistance to men regardless of insurance status. Mississippi did not. And so, as you might imagine, it's much harder to access PrEP, certainly in terms of cost, if you're a Black gay man in DC, in Jackson, Mississippi, compared to DC. Another context is about states that have laws that criminalize HIV exposure. As you can see, Mississippi is one of those. DC does it through these sort of general criminal statutes, and we don't know how much participants know about this, and so we plan to ask them this, but if they're aware of this, but we also plan to just sort of have that as an assessment measure. Another sort of example of sort of, again, context that shapes your experience and your ability to access services is just, you know, what's going on where you live, right? Another example of it's more where you live than sort of what you might be doing individually. This is from the Human Rights Campaign Fund, and they give out these sort of scorecards for all of the states and the district. And you will see that, you know, DC does fairly well in terms of good bills introduced on topics, you know, whether it's non-discrimination laws for employment, housing, and so forth, compared with, you can see lots of blanks in Mississippi, which tells you a lot about the sort of context of what it means to be, to live in a place like Jackson, Mississippi, and what you have access. So what needs to happen then to sort of improve HIV prevention and continuum for Black men? The obvious one that I've talked about this whole presentation is the importance of prioritizing and forefronting structure and power when we're talking about intersectional stigma, to ensure that we are not just sort of further stigmatizing. The second, which I think is really important, is centering the realities and experiences of what it means to be a Black, gay, bisexual man in the US. I'm often frustrated in a lot of the HIV prevention literature focused on Black, gay, and bisexual men, because what I often see is sort of this sort of framing that Black, gay, bisexual, and other men who have sex with men are just gay and bisexual MSM who happen to be Black, and that just ignore the whole sort of contextual reality of what it means to be a Black man in the US. And a lot of it is this stuff. These are just some headlines from the newspaper that have come out in the context of COVID-19. People who've been doing HIV prevention research or research with Black men know this. Black men know this better than anybody else. This is an article, the first one is by David Williams at Harvard, talking about how stress was already killing Black Americans and COVID-19 is just making it worse. The issue about masks and concerns that masks will invite racial profiling, of course, and an opinion by Charles Blow in the New York Times about all of the occupational risks and other risks that make it really tough for Black men. And then, of course, this context, right? This Black, gay, bisexual men are not immune from this stuff and how and its impact in Black communities. And so all of this from an intersectionality perspective is all interlinked when we talk about Black men. It's not just their sexual identity and what they disclose or not disclose about their sexual partners. It's this larger context of racism and what it means to be a Black man in the US. There more integration of and fidelity to critical perspectives such as intersectionality and critical race. And what I mean by this is that, you know, it's sort of related to what I was talking to you earlier, that often in research and interventions for Black, gay, and bisexual men, the sexuality part leads sort of primarily. And so that we're talking about, you know, homophobia in Black communities and all of that type of stuff, where all from an intersectional perspective, all of these are related. You can't, like, this is this wonderful quote from one of my qualitative studies about intersectionality with Black, gay, and bisexual men, that, you know, once you put in the eggs and the flour and the milk, it's all mixed in there. There's sort of not one piece that you can pull out. On the right is Philadelphia's, which you may have heard about controversial gay pride flag, where they added black and brown to the top of the pride flag as a way of sort of highlighting issues for black and brown people, black and brown LGBT people. And this also sort of comes in the wake of a lot of different racist incidents that were happening in the neighborhood of Philadelphia. And so again, this notion that you can never sort of really extricate how important racism is and how central racism is to Black gay men's experiences. This also sort of ties in with critical race theory and some work that Laron Nelson has done so beautifully in sort of critiquing sort of intersectionality and how the sort of race part as intersectionality travels, or not the race part so much, but the racism part is getting sort of pulled out. And so one of the improvements I think is that we need to be really clear and explicit that we're not talking about race. We're talking about naming and confronting racism and white supremacy and looking at that as barriers to our HIV prevention work. And fidelity to the critical perspectives like critical race theory, which says that racism is not anomalous. It's not aberrant. It's really sort of an ordinary defining characteristic of what it means to be Black or a person of color in the US. As always, we need to diversify the pipeline. We desperately need more Black, gay, and bisexual men who have sex with men as principal investigators and as members in really sort of meaningful roles as on the research team, and more training programs such as those as the visiting professors program at the Center for AIDS Prevention Studies that I'm a proud graduate of. And we also need training on structure. I come out of social psychology. I never took a course on designing structural interventions or how to design structural measures or what that means. And so a lot of us, myself included, are just trying to figure out like what do we mean when we have structure? How do we assess it? How do we combine it with individual level self-report measures? We desperately need sort of training, and we need more structural measures. This is just a quick highlight of a study that sort of used a index of structural racism that involved the segregation index, racial segregation, economic disparity index, employment disparity index, educational gaps between whites and Black people, and incarceration gap, and related it to sort of fatal police shootings, which is another area that my team and I are doing a lot of work in, which we didn't expect to. That's not where I expected to do my work as an HIV prevention researcher, but you start talking with Black men and of course, this including Black, gay, and bisexual men, and you also can't escape the role of police violence in Black communities. More community-based partnerships and collaborations. This is Open Arms in Jackson, Mississippi, where our co-investigators do a lot of work. And this need for investigators, particularly those of us who come out of the university, to really sort of partner with the real experts of their lives and their experiences, and then to address all the structural issues that come up in community partnerships, right? The fact that investigators often get their money, we get our salaries paid for and taken care of, but not so much community partners. And so we really need to address some of these sort of structural inequities that make HIV prevention research less effective than it could be. One of the things we're working on at the DCC FAR is with our community advisory board, and they're taking the lead on it, is a best practices guide for investigators who do work with community partners. We need more work that leverages strengths and assets. And this slide shows two papers that I've been relying on quite a bit in my work, because they're talking about conceptualizing resilience as structural and as a resource, not this individual trait, but a sort of, it's a resource that, you know, what are the supports in your community? In the Shaw article, they said, instead of asking about what makes an individual resilient, what is it about this person's context, their location or characteristics that predict resilience? That we need to demand that healthcare providers develop competence, structural competence and cultural competence in their work with Black, gay and bisexual men. And then last but hardly least, we need to acknowledge that the solutions are in Black male communities. That we need them as leaders, and what they need are the resources to improve HIV prevention for Black communities. And so this is just some quick examples. This is us helping Us People Into Living, a community-based organization for Black, gay, and bisexual men in DC. And also this is a campaign of the Gay Men's Health Project in the UK. And what I love about this campaign is that it really is showing this sort of culturally competent message of community collectivism and the notion of being my brother's keeper. And so again, we need Black men at the forefront of this. This is Global Black Gay Men Connect, a global Black gay men's movement. And what is what's most sort of striking about this work is about how you get this sort of holistic understanding of Black men's lives when it's defined by them and they set the agenda. HIV is not in here. They talk about a vision of a world where all Black gay men are free from criminalization, incarceration, killings, and societal bondage. And they're talking about things about independent Black gay political power, self-determination, all of that, this sort of holistic approach. And just a quick little promo. If you want to hear more, the same RFA that funded our Prism study, we are going to be doing a workshop on this at the International AIDS Conference in December, which is now going to be all virtual. We don't know the time, we don't know the date, but it will feature, there's 8 projects that were funded under this. It's ours, and I'll just show very quickly some of the studies, and all of us will be presenting. And so I'm going to end there and invite your questions, and thank you for your time, and thank you for listening.
Thank you so much. Wonderful.
Dr. Bowleg, that was just fantastic. Thank you so much. On behalf of Teo Sanford, Stephen Sukumaran, and the whole HIV Center, I want to thank you for such a wonderful, comprehensive, and rich presentation. I think your own work and your synthesis of a work across the field is just remarkable. And I also want to personally thank you in particular for highlighting David Malebranche's IAS talk. I think David is a highly respected hero to many of us, and I have to concur. His IAS talk was outstanding. I think one of the best I have ever heard at a conference like IAS. So thank you for reminding us of that. And thank you for leaving time for discussion and Q&A. So I'm going to turn it over to my colleague.
I just lost you. I can't hear you. Okay, that's better.
Okay, when did you?
I can hear you now. You drifted out for, but I can hear you. That's better.
So I hope you heard all of the gratitude for everything you did, and
you're welcome. It was my pleasure.
Okay, and if you heard, I'm so pleased you highlighted David Malebranche's piece, because that was one of the best.
I couldn't give that justice. I spoke to him yesterday, and I told him, I said, I'm going to be playing the clip because it was just so brilliant.
Yeah, it was brilliant. It's the best I've ever heard at an IAS talk, and so thank you for reminding us of that. So yes, I was saying I want to turn it over to my good colleague, Stephen Sukumaran, to facilitate the discussion. Just a reminder to everyone, put your name or your question in the chat box. Feel free to unmute yourself to ask the question and to ask your question. And those of you who are on the phone, you can just unmute yourself also and ask your question. So over to you, Stephen, and to everyone, and thank you everyone for being here. And again, thank you so much, Dr. Bowleg.
Thanks, Bob. And yes, thank you, Lisa, for such a great presentation. Our first question comes from Christina. How would you define intersectional stigma in a non-academic way? That is, one that would be accessible to the average person. The definition given earlier seems a bit too non-accessible to non-academic audiences. Mm-hmm. And Christina, feel free to unmute yourself if you have anything to add on to that.
Well, as I said, despite being sort of funded with stigma, I'm much more comfortable in the language of intersectional discrimination. And it's discrimination, sort of unfair, unequal treatment on the basis of a person's intersecting positions, and these would be positions that are historically marginalized. And so basically, I mean, the quick and dirty way would be the intersection of racism, sexism, and heterosexism, and all of these other forms of oppression or discrimination. That would be it. Just the intersection of racism, sexism, heterosexism, gender negativity. You could keep piling on, but I think that would be simplest. What do you think about that, Christina? Is that a more easily comprehend? Oh, good. Okay, I saw it. All right.
Great. We have what I think is a comment from Paul Geist. Paul, if this is a question, feel free to retype it. He says, power defined in situational, temporal, and contextual frames, power being dynamic as well as entrenched in social structures, as well as in attitudes and beliefs. There's a question mark in there, but I'm not sure it's a question. So again, Paul, feel free to retype that. Our next question comes from Wesley King. This is in regard to Prism. Wesley asks, I'm wondering if you've specified gender identity criteria for participants. I assume this is for cisgender, gay, bisexual, and other men who have sex with men, but would be interested in what Black, trans, or non-binary people who have sex with men are experiencing regarding HIV prevention as well.
Yeah, I mean, this is always sort of where the devil gets into the details with intersectional work in terms of sort of methodological issues, because it's something that we talked about in this study. I don't think we are excluding. I don't think that we are excluding, but if we do, it's because we believe quite strongly that there's a need for research studies to focus specifically on the sort of specific and particular concerns, to quote Kimberly Crenshaw, of non-binary and transgender people. What we see too often in research, including some of our own, is that gay work excludes the specific and particular concerns of bisexual men. And so in one of our other studies, what we've done is apply for a supplement so that we could focus specifically on bisexual men. And when we were doing this study, we also had the sort of same discussions about the need for research to focus specifically on gender identity and all the sort of particular issues related to that group. So I'm not sure if I answered your question adequately, and so let me know if you have a follow-up to what I've said.
That all makes sense. Thank you.
Even this is Theo. May I ask a follow-up question?
Mm-hmm.
Lisa?
Yes.
First of all, thank you for this wonderful presentation. Really comprehensive, amazing, wonderful how you bring everything together. In terms of gender, wouldn't you agree that all your cisgender men have a gender expression that will vary across the sample?
Yes, I would.
Thank you.
And I would also add on to that one of the things that's always interesting to me is how when we're talking about cisgender men, the gender piece is obscured, but that is a very specific intersection. If you look at, in a variety of contexts, particularly sort of police violence, where we've been doing a lot of our work, the police clearly see that intersection when they are targeting Black men. But I've always been interested in how, in our research with cisgender men, that they rarely mention that part of their sort of gender identity, what it means to be a cisgender man, and focus primarily on race, on the fact that they're Black. Just an aside.
Interesting.
Thanks, Lisa. A question from Adebola. It's interesting to note the complexities of race and intersectional stigma. However, in societies that are monoracial, some of these nuances are not so obvious. So how would you advance the discussion in those societies?
Yeah, great question. And something I think about a lot because I'm from the Bahamas. And so I could not do a sort of intersectional study in Nassau where race was the sort of primary, sort of race was an intersection, right? Because the vast majority of Bahamians are Black. And I've thought about this quite a bit. But nonetheless, if you looked at power, you would see that given our sort of colonial history, that the most of the money or people who are class privileged in a place like the Bahamas, a lot of those are white people. They're not, Bahamians do not have the same sort of wealth. And so that's one of the ways that an intersectional lens would be important. But the thing about I see intersectionality, like, so if you know those when you see sort of camera shoots and that they're sitting on those chairs where they sort of swivel, intersectionality becomes this sort of, I see this as the metaphor of one of those cameras where depending on where you shine, you can just see different levels of difference that tell you a lot about power and privilege in the society. So let's take race out of it. Let's take something like let's take ethnicity. One of my colleagues, Rodrigo Aguayo Romero, is doing work and writing about applying intersectionality to a place like Latin America, where the race concept is far more fluid, right? So people who there would be considered white or don't consider themselves as having race, but certainly come to the US and become people of color, but still looking at all of these different fissures of inequality. And so I think that intersectionality can be used in a lot of different contexts, just looking at power and privilege related to sexual identity or sexual minority status, socioeconomic status, disability status or lack thereof, cisgender, women and men, trans and non-binary people. And so it's just which axis do you look through? Where's that lens shining? And so I see it as a very useful framework across cultures and dimensions.
I'm going to jump back to Paul. Can you speak to the definitions of power and its transitory as well as entrenched properties, such as situational, temporal, contextual, and how that relates to or impacts intersectional stigma?
Say more. I'm not exactly sure what you mean about sort of temporal. Are you talking in just, could you flesh that out a little more for me, please?
Paul, feel free to unmute yourself.
Can you hear me?
Oh, I just get to see, I don't get to see the whole block. I just get to see little fragments of what.
Can you hear me?
Mm-hmm.
Oh, okay. Yeah, it's just no. I'm very much central on the theme about power and how core that is, and understanding how power can exist in certain forms in some situations at a certain time, but that's not necessarily what is impacting the intersectional stigma at another time or another situation. You have institutionally entrenched, culturally entrenched power. You also have contextual, environmental, socio-structural that can change depending on relationships and other dynamics. And so it's also a very dynamic and fluid situation as well as entrenched and static. And I was wondering if you had thoughts about how we should be thinking about that and researching that.
Yeah. Oh, okay. I got it now. Excellent question. That sort of fits in with Patricia Hill Collins. When she talks about intersectionality, she really talks about, I think she uses this flow of this sort of ebb and flow, the notion that people are not all have power in all contexts and all times, and people are not all disempowered and at all times. And this makes, as you can imagine, the application of those principles to HIV prevention research really tricky, because I don't know how I don't know how you sort of measure that. One of the things that we're looking for, I can just give you an example of one of our forays into trying to understand some of these complexities. We have another study that we call Strengths and Stressors. And what we're doing with that study is using sort of intersectional prism to understand social structural stressors that Black, gay, heterosexual, bisexual, and other men who have sex with men experience. And so the intersectional positions there are around sexual status, right? And so or sexuality. And so we have heterosexual men in there. But we weren't sure about how power related to socioeconomic status might affect the outcomes. And the outcomes that we're looking at are substance use and negative mental and physical health, right? And so, for example, the Black high SES man who, one might say, okay, he's in a really sort of powerful position by virtue of heterosexual status and higher SES, his outcomes might, you could hypothesize that he might have more protective or positive outcomes. We're not sure, because that could be shaped by context. So if he is a partner in a law firm, a predominantly white law firm, he's getting it all day long in terms of sort of microaggressions, the assumptions of like how he got there, all of that, does he work in the mailroom, or is he a partner, versus maybe the sort of low SES heterosexual man who works, I always use the example of a mechanic shop, I don't know, with other Black men, has fewer pressures related to, or fewer stressors related to just sort of interactions. We don't know, because we haven't really asked these types of questions before, of trying to understand these sort of shifts in power and context, and how where you live and the dynamics in this situation and how it affects the outcome. So it's an excellent question. It's not one that I have the answer to, other than one that we are just trying to tip our toe in and trying to understand these different contexts and how power shifts.
Thank you, Lisa, and thank you for an excellent talk. Thank you.
Thank you.
Thanks, Paul, for elaborating on that. We have a question from Melanie, who's with the New York HIV Planning Council. How would you change the assessments to better understand and address issues for people living with HIV receiving services?
Could you say more? Give me a little more context, please.
Sorry, so we do assessments for people living with HIV who qualify for Ryan White Part A services, and we largely don't address stigma or the impact of stigma in those assessments. I'm just wondering if you would bring some questions into the assessment in order to better plan care plans, goals, etc.
I probably would ask some of the questions that we hope to ask in Prism, and we would want, I always say one of the things we're interested in, I want to know about what happens from the time you hit the parking lot, right? And trying to assess the stigma, the context of stigma. What is it like when people are coming to get services? As an example, a non-treatment example, we have done some focus groups at George Washington University, Northwest, sort of ritzy part of town in DC. And I remember one of the participants, he came in and he was just really, he said, man, this is why I hate coming up here. Because, the way people look at me, and then he wasn't the only one who said that, right? So there's a way that there's sort of stigma for Black men from the minute how people, whether there are lots of people who look like them, how they're being asked for, how do staff treat them? How do, how many types of ID are they being asked? On all of the different ways that stigma is communicated to let people know you are not welcome here. What are the posters on the wall? You know, what happens in the context of that waiting room when you show up? How do you feel with the interactions from the person who you say, the way that person greets you and asks you about, you know, your appointment, not to mention the interactions with the healthcare providers. And so I would say, you know, asking those types of questions about as a way to understand how stigma is sort of communicated non-verbally, and to really, I think that questions like that could be really helpful, because people don't want to. I don't return to restaurants and places where I don't feel sort of valued, and I'm a person, I show up and I look at the pictures on the wall of a place I go for healthcare, and if it's all white people or it's all white men, that is communicating something to me. And so I think like those types of assessments would be important, but not as a way of just re-traumatizing your participants, right? I mean, your clients. Then what do you do with that information? How do you then sort of take that back? What sort of training needs to happen at the places where people come for care to make it more hospitable, or as you know, or to channel David Malebranche, you know, to make it a restaurant people want to come to. That's what I would say. That's how I would respond to that. Those are the types of assessments I would include.
Thanks, Lisa.
I hope that's helpful.
We have another question from Christina. Christina says, we are asking HIV organizations how they address intersectionality, giving the examples of someone who has HIV and mental illness or being an MSM of color. We find their answers focus on that they integrate healthcare across conditions and they provide case management. Is this enough? Should we be asking something additional?
Yeah. It's not just the provision of the services, right? That's one metric. But what might they be doing that are sort of further stigmatizing the clients that might be barriers to care? And so maybe the place is to ask is not necessarily the clinics, but to ask the clients about what their experiences are, and then have that information, because I think, you know, that's one of the ways that sort of power works, right? That people in power don't have to think about these things, and they might be things that might be sort of invisible to them, but are very, very visible and very real for the clients. And so I would flip that, and really, and this maps onto a core tenet of sort of critical perspectives like intersectionality and critical race theory, this notion of vantage point, that we center the groups who have been historically oppressed, marginalized, and stigmatized in order to expand understanding about something. So that I would flip that, if that makes sense.
Thanks, Lisa. Christina, any response?
Can you hear me?
Yes.
Okay. Yeah, I mean, I definitely agree. We're in a phase now where we're interviewing and surveying organizations. So probably a next phase would be to talk to clients and consumers. I also think, though, in the world of stigma research, that oftentimes we do survey and talk to the recipients of stigma and don't talk to the perpetrators enough. So I also think there needs to be a centering of the people who perpetuate stigma as well as the people who experience it.
I could not agree more.
And thank you for your talk. It was wonderful.
Thank you, Christina.
We have a question from Brian Kuttner. Brian, I'll turn it to you.
This is a great awakening to remember to consider power when doing stigma research, and I really appreciate this talk. And this is a little bit of a question that plays off of Christina's question about what do we know so far about how to intervene on intersectional stigma. And I ask that because I feel this tension between developing interventions that are like broad enough that to reach a large population, but then the problem of power that like then you neglect the populations that are the most disenfranchised. So I wonder what you might think about that question.
I totally, I mean, I totally get that tension. I get that tension as a researcher, right? On the one hand, you want the sort of population sort of impact, but intersectionality really troubles those waters by asking you to focus on sort of the specific and particular concerns. And so I say, you know, one of the things we hoped, I was talking about that other study that we're doing that's not HIV study, the study I was telling you about the social structural stressors, because one of the things that we're hoping to find is what are the riskiest positions, the most sort of vulnerable positions, right? Because I mean, you can see that that has sort of cost effectiveness built in, and then that you can actually sort of maybe tailor towards those specific issues, because intersectionality also just throws out this notion of a one size fits all. It's not, it's impossible. The services that you have to provide to the person who is homeless, the person who doesn't have access to transportation, the person who doesn't have a refrigerator, you know, those sort of basic things is very different from a person who's more sort of privileged. And so I think it's about trying to do both things at once, but I would, and I recognize in saying this that these are resource concerns, because you might not have the resources to do this sort of focused intervention for, you know, people who are homeless and don't have refrigerators. But I think that's really, we need to start thinking about these sort of more sort of specialized projects, this more specialized focus to have greater impact. And you know, you know, maybe that's more. I also, in saying that, realize that could be more of sort of a sort of theoretical academic answer from somebody who does not. You know, I'm a researcher. I'm not a service provider, and so I imagine there are all sorts of complexities that I haven't even thought about that just can't answer your question. Give the due diligence to that question that you deserve.
Thanks, Lisa. Andre Titus asks, what would you suggest to a counselor that has a client that is struggling with intersectionality? And Andre, feel free to unmute yourself if you'd like to expand upon that.
Yeah, give me more context, please, Andre.
Okay, what happens sometimes, a person may not understand the word intersectionality, and so they, in terms of counseling that person, they can't see how these components affects their growth in life.
Mm-hmm.
So it's about finding some skills or technique we can do. So what would you suggest for counselors to start with?
Well, I think I would lead with sort of what's important to that person. You know, one of the traps, and again, let me throw out the caveat. I am not a clinician. I am a social psychologist. I'm a researcher.
Yes.
So I've never done therapy in my life. But you know, sort of one of these, it's sort of like Pat Parker, who is a sort of Black lesbian poet, and had this poem, something, it was something like, to the white person who wants to be my friend, first you must forget that I'm Black. First, you know, second, you must never forget that I'm Black. And this notion that, you know, we need to let people tell us what's important to them first. And the onus is on, and again, I'm speaking from a research perspective, the onus is on researchers to know about the context of racism and the history and legacy of racism and how that impacts people regardless of whether or not they say they're Black or they've experienced racism or not. And so I think it's about counselors becoming sort of really sort of structurally competent, structurally knowledgeable. Like if you're working with diverse clients, if you're working with a Mexican American trans woman, you need to know about what it means to be sort of the Mexican American. You need to know what it means to be trans and the intersection of those, but not necessarily that you ask people about, you know, tell me how you experience intersectionality. I'd say not relevant.
Yes.
But that it's, the onus is on the counselor to develop some competence about what it means, and to ensure that as you're talking, you're not just focusing on sort of one identity as if it's independent, as if it just doesn't exist. You know, that you can just talk about the race part over here and the gender part over here and the class part over here as if they aren't all interlocking. Does that help?
Very much so.
Oh, good.
Thank you so much.
You're welcome.
We have time for one final question. Natalie asks, what are your recommendations for early career researchers who are people of color and receive pushback on wanting to focus on systems and the funders seemingly biased for a focus on individual level studies?
Oh, I love this question. Advice. I say stick to your guns and follow your truth in this. I mean, I know that's really hard, particularly if you are a graduate student in a department where faculty are telling you like qualitative research, that's not real. Or why are you talking about racism? That's not real. How are we going to measure that? And so, you know, sometimes you got to do what you got to do to get by, but really it is possible. And I'm an example of that, of somebody who's been pretty non-compromising in terms of talking about intersectionality and racism and all of that. But you need the training. I mentioned the Center for AIDS Prevention Studies visiting professors program in my talk, and I really advise that you look that up. I would not have a career if it weren't for that program. I worked full time when I was doing my doctorate. And so that means that I didn't have opportunities to be a research assistant with professors. And so and also I tell people I couldn't get an academic job today. And so 20 years ago, more than 20 years ago, when I got my academic job, I had one publication for my dissertation in press. And that program is designed to train investigators, particularly people who are doing research in racial and ethnic minority communities around HIV prevention and substance use, about how to write NIH proposals. I didn't even know what an NIH proposal was when I got my doctorate. And so it's sort of learning, okay, how do you say these things in ways that'll get you funded? And you have to stay true to that passion. We don't need another cadre of researchers asking the same old questions and not challenging the status quo. And so I really want to encourage you. So drop me an email if you need some fortification on this about why it's so important. And so I say the fight is worth it. And if you can't do that in your, you know, because you got to get that degree, right? Nothing's going to happen until you get the degree. And so if you got to make some compromises there, that's where you do it. But after you get out, it is about being explicit about racism and inequality and power and social inequality, and bringing what you know to be true to the forefront with the hope of being able to change things and be an agent of change. That's my long-winded answer to you.
Thank you so much, Lisa. We're going to cut off the Q&A portion here in the interest of time. Thank you for everyone who participated. And
Rico, I say Rico, I have to wave.
And I'll hand it off to Bob for final comments.
Thank you, Stephen. And thank you again, Lisa. Lots of applause all around. You can see from the discussion, this could have gone on easily for another hour. Great enthusiasm. Yes. And in case you didn't hear me earlier, thank you for such a rich and comprehensive presentation, and also handling the discussion. I think your own work and your synthesis of the work in the field is just remarkable. We can't thank you enough. And thank you everyone for being here, and be healthy, stay safe out there, and let's keep supporting each other in everything that we do. Take care, everyone.
Thank you.
Thank you, man.